When starting internship, there are a ton of things to know. Of course, there's all the purely medical things: how to interpret an ECG, which antibiotic covers which bacteria, what's a diagnostic framework for abdominal pain, etc. But you hopefully learned all of that, or at least were exposed to most of it during medical school. There's also all of the logistical, practical knowledge necessary to get the work done, like how to use the EMR and how to reach a subspecialty consultant. You'll probably learn about these things during orientation, or you'll get a crash course during your first day on call. But none of this information is mysterious or a secret. It's all written down somewhere. However, there are some unwritten rules of being an intern. These are things that all interns need to know, or will learn at some point relatively early during internship, but which you can't look up in a book, and which won't be learned because your program director is not going to sit down and explicitly tell you these things during orientation. Some of this is the so-called hidden curriculum, and some of it is just how members of the healthcare team interact with one another. The following are just 10 of the many, many unwritten rules of being an intern. When you're at the nurse's station, do not sit in the chairs belonging to the clerk or the charge nurse. These chairs, they'll not be labeled, and if you're relatively new to that unit, you may not know who is who at the station yet, or which computers are spoken for. But if in doubt, just ask. There is no quicker way to end up on the clerk's blacklist than to sit in their seat and use their computer. Don't forget about your medical student near the end of the day. Remember, you were in their shoes very recently, sitting there twiddling your thumbs in the corner during your final hour of call, wondering how it would be perceived if you asked if it was time to, or if it was okay to go home. If the day's just about done, your student has completed their notes and any other patient-related work, and notable additional learning opportunities are unlikely to come up, please be proactive in letting them know they're good to go. Use your pharmacists. I think many house staff and attendings alike freely call the hospital pharmacist when they need someone to manage vancomycin or warfarin, but then otherwise kind of forget they exist. However, pharmacists can be a great resource for all kinds of other information. Are you admitting a patient on 20 different medications, and you're concerned about drug-drug interactions if you're about to start the number 21? Ask pharmacy. Does your patient seem to be experiencing serotonin syndrome, but you can't identify the culprit? Ask pharmacy. Does your patient have an unusual collection of infections, and you're looking for the most elegant antibiotic regimen that will cover everything? Ask pharmacy, particularly if your hospital has a specific ID pharmacist. For pharmacy is not just there to manage warfarin and approve your med orders without discussion. If you take from common food within a shared workspace, you need to periodically contribute to that common food supply, with the exception of a food supply which is provided directly by the hospital or residency program. Do not speak disrespectfully of patients, ever, even if you're in the privacy of the team room, and even if people more senior than you are doing it. While we all know that some patients are particularly skilled at triggering challenging bedside encounters, and certainly patients can be rude to us, speaking of them with disrespectful language will bias you towards providing them worst care. And if someone not on your team walks in and overhears you insulting your own patient, they'll be left with a very negative impression of yourself and the care that you provide. If there are fewer chairs in the room than people, I'm sorry to say, but those chairs, they go to those with the greatest seniority. Unless, of course, someone more junior has a medical reason to be sitting, including pregnancy. However, if someone more senior than you offers you their chair, don't argue. It's not a trick, it's not a test. Just thank them and sit down. If that attending or fellow really wanted the chair for themselves, they wouldn't have offered it to you in the first place. While there exists a gray zone between reporting mistreatment and an intern complaining about legitimate criticism by someone more senior than them, most attendings, we want to know when when our intern feels like they have been mistreated by someone. How can you tell if something is legitimate criticism versus mistreatment? You know, just because a doctor or nurse criticizes something you've done, and just because it made you feel bad, that doesn't mean you've been mistreated. All of us make mistakes. Even attendings make mistakes. And in order to learn, we should welcome someone correcting us. And being corrected, of course, it usually does feel bad in the moment. And that's okay. Feeling bad about it helps us to remember not to do that thing in the future. But on the other hand, if the message was delivered as an ad hominem attack, like, wow, you're really stupid, aren't you? Or if it was delivered with racist, sexist, or homophobic undertones, if the other person was literally yelling at you, or if the way in which the criticism was delivered involved deliberately embarrassing you in front of others, all of that is mistreatment. And if it happens, your attendings want to know about it. Mistreatment of house staff and of interns, it affects the psychological well-being of a member of our teams. The person who's mistreating you needs feedback themselves to not do that anymore. And ultimately, mistreatment of house staff negatively impacts patient care. When it comes to bounce-back decisions, which is often up to the resident and not the intern, but nevertheless, strike a balance between taking ownership of your patients and doing what makes sense, rather than just being dogmatic with whatever the official rule is. So, some specific examples of what I mean. Consider if another team discharged a patient after an unremarkable one-day stay for cellulitis, and then the patient returns to the ED 3 weeks later with an unrelated COPD exacerbation that has nothing to do with the previous admission. And you happen to be on call, you don't need to bounce them back to the first team the next day just because the residency program rules say that you can. Likewise, if you pick up a patient who was readmitted after a week, but the original team currently has substantially more patients than your team, it's okay to hang on to them. And last example, if you send the patient to the ICU and the following morning they are ready to come out of the ICU on a day that you're not on call and would not normally be accepting ICU transfers, even though the rules might say the patient should go to the on-call team first and then bounce back to you on your next call day, if everything is straightforward and you have the bandwidth to accept them and you feel like you have good resident support, just go ahead and accept them. It's okay. Fewer handoffs will make for better patient care, and reducing workload to the on-call team is usually a good idea. Call consults early in the day. Not only will the consulting fellow appreciate it, the quality of the consult will likely be better as the whole consult team will have an opportunity to fully evaluate the patient instead of either being rushed at the end of the day or instead of the fellow just giving some quick curbside recs because their consulting team's once daily rounds have already occurred. And finally, the last and most important unwritten rule for this list: never lie. Faculty and fellow house staff and the nurses and the pharmacists and respiratory therapists, they're able to forgive a lot of stuff. A forgotten progress note, unwarranted Q2 neurochecks, using the clerk's computer or sitting in the attending's chair, even, more seriously, even a one-time disrespectful exchange. Whatever you did, if it's accompanied with a succinct explanation and a sincere apology, it's usually not a big deal. But lie even one time about something you either did or didn't do, and that's going to stick with you for the rest of residency. Aside from the fact that lies about patient care, jeopardize patient safety, whoever catches you in the lie, even a small, seemingly insignificant one, they're not going to forget it, because someone who has a tendency to lie once has a tendency to lie frequently, and other people are going to know that. So those are 10 of the many unwritten rules of internship. Feel free to add more to the list in the comments below.